Ms. Carey.
Thank you, my lady. May I invite Dame Ruth May to be sworn, please?
I swear by Almighty God that the evidence that I shall give shall be the truth, the whole truth, and nothing but the truth.
Sorry, I just had to send a message. I've got the wrong notebook. Someone could go and get the right one. I'd be grateful.
Thank you. My lady, may I make a start on some background matters?
Do, please.
And we will
I can catch up.
remedy the notebook. Dame Ruth, your full name, please.
Ruth Rosemary.
You made a witness statement to the inquiry dated the 17th of May of this year, INQ 479043, and I hope you have a copy of that in front of you.
I do.
Right. A little bit of background about you, please. I think it's right that you've been a nurse since student days in 1985.
Yes.
You were made the Chief Nursing Officer in 2019
Yes.
until you retired in July of this year.
Yes.
Can I ask you, please, and if it helps you to refer to your statement, please do, just give us an overview of the role of the Chief Nursing Officer.
I was the former Chief Nursing Officer for England from January 19 to end of July. I was the most senior nurse in England. I led my profession, and I was the advisor to the government, to DHSC, and to the NHS on nursing.
I think you said there are currently around 386,000 nurses and midwives working for the NHS in England.
Yes.
And is it right that you do not line manage the nurses?
Absolutely.
I think you said in your statement that you have 3 categories really towards your work, and if it helps you, paragraph 17, Dame Ruth, you say you are accountable as an executive lead. Can you give us an example of what you did in that role?
Of course. So as a professional leader, I led on some of the national programmes. For example, international nurse recruitment, maternity, nosocomial transmission programmes.
You also say part of your role is to act as a collaborator. Again, an example of that, please.
I worked with my National Medical Director on the DNACPR. We worked to promote the practice on that.
Is that Sir Stephen Powis?
Yes.
Thank you. And you also have a role as a stakeholder or advisor. Again, an example of that, please.
Of course. So the Black Asian Minority Risk Assessment, I was an advisor to the CPO and to NERB, and my views I'm sure we'll come to.
Right. I think whilst you were the Chief Nursing Officer and during our relevant period for Module 3, you were supported by 4 Deputy CNOs, and there were Chief Nurses in each of the 7 regions in the NHS in England.
Yes, there were. There were regional chief nurses who had the responsibility and leadership to support the trust chief nurses, and they worked very much as part of my team CNO.
Thank you. I'd like to look at your responsibilities during the pandemic itself, and it may be that during the course of my questions to you, Dame Ruth, I'll ask for documents to be called up on screen. Before I do, and without causing you, I hope, any embarrassment, is it right that you have dyslexia?
Yes, I do.
Right. If I go too fast, or you want to take a moment to read through a document, please will you let us know?
Thank you.
So to the pandemic, please. You say at your paragraph 27 that you were the senior responsible officer for NHS England's IPC cell. Help us, please, what you did as the senior responsible officer in relation to that cell.
So the IPC, UK IPC cell was a consensus group. I was responsible for IPC in England. The group was made up of professionals, public health professionals, microbiologists, IPC nurses from across each country of the UK.
We heard yesterday from Dr. Ritchie, so we're a little bit familiar with the cell, and indeed we'll be hearing from Laura Imrie, who was also a member of the cell. Were you actually on the cell, though?
No, I wasn't. So my oversight came through, I met with Dr. Lisa Ritchie, Professor Mark Wilcox, the National Clinical Director for IPC, and my Deputy CNO with responsibility for this, almost on a daily basis during COVID, during the relevant period, together with being a member of the hockey working group.
So just pause there. That's the Hospital Onset Commission Infection Working Group?
Indeed.
Thank you.
So together with being a member of that, I was being able to see and hear views from across the whole of UK. We were from public health specialists, microbiologists, and from infection control nurses. We relied as well on data, what the data was telling me. And I think finally my oversight was partly by membership of the senior clinical group as well.
I was going to come on to that.
Okay.
If I may. I think that was a group that was made up of who, please?
The senior clinical group was chaired in the early days always by the Chief Medical Officer of England, and then it rotated chair between the UK CMOs. It had Public Health England, senior doctors, Professor Harries, and then she went on to be the Chief Executive of AXA. Had the Public Health Senior Medical Advisor, Professor Susan Hopkins. It had the National Medical Director, Sir Stephen Paris, and it had all 4 UK countries, CNOs and CMOs.
Right. I think that group is sometimes known as the Senior Clinicians Group or Senior Clinical Group. And is it also known as the Senior Clinical Leads, or is that a different group?
I always knew it as the Senior Clinical Group, Clinicians Group.
And so that group of senior clinicians had oversight of the IPC cell?
The IPC cell was a consensus group. It was not a decision-making group. IPC members used to go back to their country, and their country then would make the decision. So, for example, in England, it would come to me and I would take a paper, often with the National Clinical Director, Professor Mark Wilcox, to our NERB, our decision-making group. But always, after each country had taken it back to their decision-making group, it would go to PHE or AXA for the final oversight of the content of any IPC guidance.
Pause there, so I want to be clear. The IPC cell make a recommendation. It is seen by you and or Mr Wilcox in relation to England, equivalents, I assume, in Wales, Scotland and Northern Ireland. Once it's been seen by those 4 nations, are you saying that PHE, AXA as it became, still had final say?
Absolutely, yes.
Right. So there's a number of levels of authority that it's got to go through before it ends up being published?
Absolutely.
If you and or Mr Wilcox said you didn't like a recommendation made by the UK IPC cell, what would happen practically?
So we would look at it, we would debate it. My role, of course, was around the operational implementation. So I had a view around how cohorting would work, how we would support staff in that. Then, of course, it would go to PHE and to AXA for the scientific sign-off of the guidance.
Right. So if you disagreed with the IPC cell, presumably you'd make your views known. Would you go back to the IPC cell and say, I don't think this is quite right, it's not going to work on the ground? How would it actually evolve?
So my role was to question, to challenge, to ask, have the IPC cell reviewed and considered the latest evidence, and I've done that a number of times during the relevant period, as all UK CNOs did.
Mm-hmm.
we all, collectively and individually, would always challenge and do that. But of course, the scientific advice came from the scientists. So public health doctors, I looked to the public health doctors a lot to give me that scientific advice, as well as the UK IPC cell. And of course, they had public health doctors within theirs, as well as other professionals.
Right. So if there's some, don't take this pejorative, backwards and forwards between you and the IPC cell, between the four nations, hopefully agreed position amongst all of you. But are you still saying that even if you all agreed, Public Health England and UXA, as it became, could still say, we don't think this is the right recommendation to make? We don't think this guidance is correct?
Absolutely.
Okay, all right. We may come back to that, Dame Ruth, in a moment. I think one of your other roles in relation to the pandemic was you were an executive, as an executive director of NHS England, you attended the COVID-19 National Incident Response Board. Help us, please, with what that board did.
It was often referred to as NERB. It was the decision-making group within NHS England. I was an executive director around there. I took almost 60 papers to that group during the relevant period.
I think you said they met 3 times a week or more.
Yes.
During that. You obviously engaged with your fellow CNOs in Wales and Scotland and Northern Ireland. And you said that there were 26 meetings just between March and May of 2020. You clearly worked with Chief Medical Officer, Sir Chris Whitty. You've told us about the Senior Clinicians Group. You met with the Secretary of State, Mr. Hancock, and in due course, presumably Mr. Javid.
No, I didn't.
Or you didn't meet him. All right, thank you. You worked with PHE on IPC guidance. And one other aspect I'd like to ask you about is your engagement with frontline nurses. If it helps you, Dame Ruth, I'm at paragraph 54 in your statement. But I think there you said there was initially an informal advisory group, which then in due course became more formalised. Tell us about that transition.
Thank you. So we were facing some extraordinarily difficult decisions in the very early part of the inquiry. Difficult because it was a fast-moving environment, a time when we were seeing a number of cases come in, deaths that we hadn't seen like we'd seen before. So I wanted to check out the views of potential actions I was taking with some of the most very senior and experienced nurses. So I had a telephone book of probably the most forthright nurses in England at the time, and I chose them because I wanted them to give me their value of their experience, their expertise, but also they weren't going to say, yes, of course, you know. They were going to say, well, that won't work, that will work, have you thought about? And that really helped me and helped me make some tough recommendations and decisions.
You spoke there about your contacts with senior nurses. What about with those less senior on the front line?
Yes, so I had a shared decision-making councils that we set up in May 2020, and they were made up of frontline staff from all over England, of all sorts of backgrounds and settings. They reviewed what we were doing. I used to go to them with questions. I attended a lot of their meetings, and indeed I'm seeing them tomorrow for my final meeting with them. I also, of course, visited like I would do pre-pandemic and post-pandemic.
Yeah, I want to come on to the visits as a slightly separate topic. So you were having some input through the Shared Decision-Making Council from those on the front line, and in addition to your contacts with the more vociferous senior nurses that you've told us about. All right.
And with the Chief Nursing Officer, Black Asian Minority Strategic Advisor, their SAG, they were invaluable colleagues.
I wanted to actually just ask you, please, about your involvement with the I think they're called CNO SAG. It's not a particularly attractive name. Just help us. What does that stand for, Dame Ruth?
The Black Minority Ethnic Chief Nursing Officer Strategic Advisory Group has been running now for 22 years. It's made up of people from a Black Asian minority background, nurses from all levels across the whole of England, and they are the most wonderful group to work with. They champion, they support each other, and they did some great work to support their colleagues and to support our national decision-making during the relevant period.
I think you say at paragraph 60 in your statement that thanks to the links through that group, you were involved in raising the issue of disproportionate impact of COVID on the Black, Asian and minority ethnic staff and indeed patients in April 2020. Can you just, perhaps by reference to paragraph 60, set out, please, some of the issues that came to your attention?
Yes, so they had held a number of teleconferences across all of the 7 regions with frontline staff. And it came through that they said that there were some people, particularly from a Filipino background and particularly women, that some of the masks weren't fitting properly because of the shape of faces were different. I took that, and my deputy CNO developed a program, an improvement program, to increase the number of types of masks. And indeed, there were 8 additional FFP3s available then for staff as a result of that program. That was where listening to frontline staff, for me, made a change in a national policy.
Although with that, the need to fit test another 8 different types of FFP3 mask. Can I ask you about this whilst dealing with this topic? Can you help? When did you first become aware that there was an issue of disproportionate infection and indeed death rates amongst Black, Asian and minority ethnic healthcare workers?
Yvonne Coghall, the then Res Director, emailed me, I think it was the 7th of April, I think it's in my statement here somewhere, but she emailed me raising that. I immediately talked that through with colleagues in the Strategic Incident team. And then the next day, I believe, we had a senior clinician meeting and I raised it with my senior clinical colleagues. And that is when the Chief Medical Officer for England commissioned some further work.
Yeah, well, we're going to be hearing from Sir Chris Whitty next week. May I ask you this, though? There's a lot of people that say they raised issues, they spoke about it with colleagues, they escalate it, to use a phrase that is often used. What practically do you think could be done to help minimise the disproportionate infection and indeed death rate on Black and minority ethnic healthcare workers?
So there was a risk assessment process that was established for making sure that workers from a Black, Asian minority background, from all backgrounds, not just nursing midwifery professions. It was led by the CPO Directorate, and you will know that I raised later, I think it was early June, that I wanted that risk assessment process sped up because I was hearing from, again, my colleagues from the Black Asian Minority Strategic Advisory Group that there were still people without a risk assessment, and I wanted that sped up.
We will turn to that a little later in your evidence. Aside from the strategic SAG group that you spoke about, was there any other way that you came to learn about issues and concerns faced by ethnic minority nurses?
The Jabali Network, which was a group of male men in nursing. It started off just literally before lockdown, 9th of March 2020. There was 9 of them, and now there's well over 100. They would give me feedback. And of course, I worked on the front line myself.
Taking all of those different sources of information, what would you say were the key issues and challenges being faced by Black and minority ethnic nurses and midwives?
It was tough for them. Tougher for them than people from my background. If I think back at the Nightingale, there were 30 patients, and all but one were from a Black Asian minority background. And that was replicated in critical care units. And then if you were staff treating patients that were also looking like you, that was tough for them, very tough. And so that's why we did a lot of work to support the associations. So this was the Filipino Nurses Association, the British Indian Nurses Association. There were 3 of them at the start of the pandemic, and I think now there's 36 of them. So we funded a small grant process to support them to do that. But it was tough for Black Asian minority nurses, particularly seeing so many patients from the same background.
You set out in your statement the work you've done with the Royal College of Nursing, the NMC, and like associations. I think you said in your statement that you didn't always necessarily see eye to eye with the Royal College of Nursing. Are you able to give us some examples of where you didn't agree with them and how that impacted either your response to the pandemic or indeed their response to the pandemic?
Thank you. So I had a very good relationship with Dame Donna Kinnair and then Pat Cullen, the chief executives during the relevant period. It was always a robust relationship, as it would be with any college/stroke union. But we always had nurses and patients' interests at heart. So Dame Donna, particularly around PPE, and I were in conversation where they supported the guidance. But I knew that there were, particularly later into the pandemic, members within the RCN challenging some of the IPC guidance, for example. But at my level, chief exec level, we had a very robust and challenging but excellent relationship. And I'd say that the same with Pat Cullen.
In relation to IPC, would that be around the provision or otherwise of FFP3 masks?
Yes, and indeed, the beginning, it was around gowns and aprons.
Fine. We're going to come on to look at some of these specific issues with PPE supply. Finally, you've alluded a number of times already to your work on the front line, and I think in your statement you say you worked during our relevant period on wards on 29 occasions and indeed undertook a number of visits of different wards, including critical care units. Help us, please, on any or all of those occasions. What was it like?
An utter privilege. Excuse me.
It's all right.
Have a quick drink of water.
Please do.
Take your time.
Thank you, my lady. It was an utter privilege. It really was a privilege to be a nurse.
What did you see? Tell us, Dame Ruth. Give us a little insight into what
Yes,
was
of
going
course.
on.
So early on, I did 2 shifts at the Nightingale. The first time I've already referenced. The second time was literally on the way back from my stepmother's funeral in Wales. I then did an evening shift. And I actually nursed to nurse, which was a privilege to do. I worked
I visited inclusion nurses, nurses that work in homeless. I visited a care home. I had a great privilege in December and January to work in the vaccine programme. That gave me hope. But I also worked in ITU on a Sunday morning. Under the radar, worked alongside colleagues. There was death. There was death. There weren't visitors. Nursing ratios were stretched. But it was very powerful because I was able to go back then to Matt Hancock, to the Secretary of State, and go, this is what my recommendation is. No, we're not doing that. Yes, we are doing that. So it gave me a real live experience of what it was like to wear full PPE. And Dame Donna was with me on the first time in Nightingale, but nurses were at the brunt of this.
What was it like wearing full PPE from a practical perspective?
Oh, yeah. I was a theatre nurse by background, so we were used to wearing masks, but not FFP3, of course. I was fit tested at the Nightingale, but I was fit checking every shift I did when I was at Colchester, going into working alongside colleagues at critical care. They gave lots of nurses, including myself, indents into our cheeks. But they were the protection that was needed for critical care units. But it wasn't just the mask. It was the eye protection, the gown, the glove. It frankly took ages to get everything on and off.
We might come back to that in a moment. Can I change topic?
Of course.
I'd like to ask you, please, about pre-pandemic work issues. And Dame Ruth, if it helps you, I'm in paragraph 88 in your statement.
Yes.
And I think you say this: as at December 2018, there were workforce vacancies in the NHS in England alone of 39,686 nursing and midwifery vacancies. Call it 40,000 just for ease. There was some increased funding given, is that right, to provide 5,000 additional places for student nurses?
Can I ask your permission to provide a bit of context before we get to that?
Of course you can.
So, you're right, there was very nearly 40,000 vacancies. In England, which is different to the other devolved nations, the bursary was removed.
Is that a student bursary or a...
So,
help us with that.
in 2017 or 2015, the then George Osborne Chancellor announced that they would get rid of the student bursary, which is in effect the student fees were paid for and a maintenance grant, which meant that there was a significant drop, indeed a 23% drop in nursing and midwifery applications as a result of that. So instead of nurses being trained, like I was, like many other nurses were, when we received free education and a maintenance grant, nurses and midwives now as students, well, at that period, were not receiving that. So they ended up in a lot of debt. That meant, and HEE colleagues have done some analysis of that work,
Is that health education?
Health Education England. They've done some analysis of that work, and it meant that we were 5,000 fewer nurses in March 2020 because of that decision, and 700 fewer midwives in March 2020.
So you have a general deficit in 2018, but come the start of the pandemic, a significant number of fewer nurses and midwives.
5,000.
5,000.
5,000 fewer nurses at the beginning of the pandemic because of the bursary decision.
Can you help us? How does that play out on the ground? If you had 5,000 more, maybe put another way, how many extra nurses would there be in a hospital?
I reckon it would be about around 40 extra nurses in each hospital. Now, of course, hospitals are different sizes. That, I think, would have made a difference. Maybe we needn't have made some of the decisions around critical care ratios. And of course, if we had more nurses, there'd be less burnout. There'd be less psychological impact. Removing the bursary, for me, was a catastrophic decision.
All right. Let's look at a programme in 2019, I think, launched by the Department of Health and Social Care to deliver 50,000 nurses by 2024 and 2025. Now, basically. Is that new recruits, or getting people who are off the register back, or international recruits, or increasing students? How are they going to make up the 50,000 nurses as part of this plan?
So just before that, of course, we had the £5,000 maintenance grant that I championed and the government supported. Indeed, Matt Hancock supported that coming in place, which was a support to attract nurses, and that did work. But it wasn't still free education. But going on to your point, the DHSE launched the 50,000 programme, and it was 50,000 extra. So, of course, we had to recruit and retain more than the 50,000 in order to allow for people leaving and retiring. I was responsible for international nurse recruitment, and at the time we had an aim to deliver 18,000. Of course, we completely exceeded that, and we'll no doubt come to it. And HE colleagues at the time had a role to increase domestic nursing supply with the aim to get to 19,000, and the CPO nursing retention was 13,000. So that 50,000 was broken down into international nurse recruitment, domestic supply, and retention.
Right. All right. Can I ask you this? I think there were projections for between 20 and 30% staff absence in England alone during the pandemic. Does that mean on any given day or week it would be predicted that there'd be up to a third almost of nursing staff missing? Or is that too simplistic a way of looking at it?
So the way I recall it was the strategic EPRR director, Professor Sir Keith Willett, wrote out to myself and to Steve Powers and said, we're going to be 20 to 30% short. It was because that was the formula that as part of the pre-pandemic planning. I think that's where it came from. So increasing workforce supply was a key action for me.
Right. Maybe I've not made myself clear. You're going into the pandemic with a deficit of nurses and midwives. Then there is the impact of the pandemic, so nurses getting sick themselves or isolating, which could cause a 20 to 30% absence rate. The 50,000, was that meant to cover the pre-pandemic deficit and or the absences caused by the pandemic itself? The
pre-pandemic.
Right.
And the 50,000 programme was a step towards the vacancies. My recollection was in modelling, it should have probably been an 85,000 programme, but it was a £50,000 ambition that the government set.
And what happened?
We delivered 64,000 additional nurses.
So I'm not following. You spent some time, and there, as you'll understand, there's a limit to how much I can go into austerity measures and party politics and the like,
Of course.
and who decided to introduce fees for education and things. But you did say that you blamed the withdrawal of the bursary for the fact that there were fewer nurses, but now you've said that the programme recruited 64,000 additional nurses, so I'm not quite following.
So we went into the pandemic with nearly 40,000 vacancies. We would have had an additional 5,000 vacancies at the start of the pandemic if the bursary hadn't been removed. The 50,000 ambition came because nurses were going to carry on increasing in need and demand. So the government decided to have a 50,000 ambition. I supported that. We actually delivered by November 23, with using September 23's data, we delivered 64,000 additional nurses. So at the start of the pandemic, September 19, the programme was launched. We worked hard to increase the number of nurses, and even harder throughout the pandemic to make sure that we over-delivered against that.
Thank you. Was just briefly asked you about staff absences. Can I just ask you about long COVID absences in nursing? If it helps you, further on in your statement at paragraph 219A, but I think you attended a meeting, certainly in December of 2021, looking at the issue in relation to long COVID absences and the impact it might have on nursing. Can you just summarise what you learned at that meeting, and indeed what was your takeaway in relation to the impact of long COVID on the nursing profession?
I believe this was the round table chaired by Lord Bethell.
It was.
My medical director colleagues, Nikki Kanani, Kathy Hassel, they presented a paper on long COVID to the Minister with what they were doing on that. I took away from that meeting and others that we needed to support nurses supporting patients with long COVID, and that's why we developed a framework to do that, to support them.
Oh, and in a nutshell, what did the framework achieve or set out to achieve?
It set out to support nurses because this was new. It involved multi-professional working and nurses from all sorts of clinical backgrounds. There were I received some advice from Dr. Elaine Maxwell, who was very helpful in this area, and we got experienced people that were through life were experiencing long COVID to support that framework development by one of my deputy CNOs.
Can you give us a practical example of support, perhaps not provided by you, but through the Chief Nursing Officer Directorate, how practically you supported people with long COVID?
Well, people with long COVID, there were often nurses that had long COVID. Most of the support for that came from how we supported them with their pay, their terms and conditions, how we got them back to work in a part-time capacity, in a very different capacity. I met one of the long COVID nurses on a Teams call that was describing how she's now doing part-time research and part-time in her old job, so that it supported her back to her full health.
Looked there briefly at some of the issues going into the pandemic and some attempts to increase nursing capacity. But can I ask you about 4 specific ways that nursing capacity was increasing? Can we call onto screen, please, 421158 at page 2. If it helps you, Dame Ruth, it's in tab 2 of the bundle, but it might be easier just to use the screen. And this was a letter that you wrote on the 6th of April from you and indeed the Chief Nursing Officers of all 4 nations, I think, outlining the 4 ways that it was intended to increase nursing capacity. The first one there is once the government has passed the legislation, thank you, to enable the NMC, the regulator, to establish a COVID-19 temporary register is our first focus. We'll be inviting those who've left the register within the last 3 years to opt in should they wish to do so. All right, so to get people who've come off the register in the last 3 years back onto the register, why was the 3 years chosen?
Because it could give us a potential 50,000 people. The NMC looked at the data and said that they thought it was 3 years would be the right number of years. UK CNOs debated that and agreed, and so it was 3 years. Later on, we did longer.
Thank you. I'm going to come on to that, but I think you said it was anticipated that if you went back 3 years, the NMC that thought it might give you a cohort of around 60,000.
In the UK and
51,000.
51,000.
All right, so that could potentially fill the gap.
Yes.
All right. It was aimed, I think you say, at people under 65 who are perhaps now working in different areas of the healthcare market. You widened that, though, as I understand it, to cover people who'd left the register within the last 4 to 5 years. Why was it widened from 3 to the 4 to 5?
Because the picture we were facing with COVID and the number of patients coming into hospital was increasing at a further rate. So we needed to take further action.
Was it thought that those who'd left within 3 years would effectively be more up to date with their skills, if I can put it like that, than those perhaps when 4 or 5 years has lapsed?
Indeed.
Right. But notwithstanding that, the need was such that you needed to go back 4 to 5 years. All right. Now, whether it was 3 years off the register or 4 to 5, can you help us with what plans were put in place to ensure that those who were returning were sufficiently skilled and up to date?
So each of the trusts where people went, nurses went, they did an induction program, they did some key skills training. But it depends on where they were. So I worked alongside some children's intensive care nurses. Of course, they've got very real and very transferable skills. I also worked alongside some people that had been in education and not been on the register but wanted to support. They needed more of those skills. But of course, we were in the middle of a global health emergency. We weren't going to be able to provide an induction program over 12 weeks that you would potentially provide in peacetime. This was unprecedented times.
Now, I think expressions of interest from those who were potentially returning did not always equate to staff actually being employed. Can we have a look at that, please? And can I ask that was put up on screen 421170.
Which tab?
It is in tab. I've got the wrong note, but we'll put it on the screen and we'll just work off the screen. Now, this is a very long email
yes.
setting out the returners. And can we go to page 68, which is position at the beginning, and as you go through an email, inevitably we end up at where we need to be.
Yep, I've got it.
Bottom of the page there, this is the position
Yep.
very early on, just as we're about to go into lockdown, as at 11:30 a.m. on Saturday the 21st of March. The NMC had received nearly 4,000 applications to join.
Yes.
Can we just go to page 67? Day later, it's gone up to 5,633 applications. And I'm going to jump forward a month to page 4, if I may, please.
Yes.
It's just coming on screen now.
Yeah.
Set out in a slightly different format with more detail, but here we are 1 month on from the nearly 4,000, and now we can see the NMC confirm there is nearly 12,000 nurses and midwives across the UK on its temporary register. And the data has now been broken down into midwife nurses, into which country, and indeed which age bracket they're in.
So the NMC set this up very quickly, and we appreciated that by the UK CNOs. And of course, we understood that it was UK data to begin with, but as soon as they could, they broke it down, as you can see.
If we go to page 3, there is an email, I think, from you at the top. Great to have nearly 12,000 back on the register. How many of these have done their first shift? And that really brings me on to the point that just because you went back on the register did not necessarily result in people on the ground.
Absolutely, and I was corrected by Scott in my team quite rightly, because that was the UK figure, and the England figure, as he then further goes on, was less. But that was my first time going, it's all very well having them on the register, temporary register.
But what next? So let's look at page 2 of the document, please. Yep. And there's an email from Scott Binion.
Yes.
Setting out, just for England, you've got 9,841 opting to the temporary register.
Yes.
Of whom 8,950 are passed to the regions for deployment. Deployed by regions to the front line, we go from 8,950 to 2,785. Can you help with the decreasing numbers that we see set out in that table there? We'll leave 111 for a moment, but how come is it that there's a lot of people looking to join the register, but when we get to deployed to the regions, by regions to front line, it's 2,785?
I think this is one of the areas of learning for us. This was an issue that all 4 countries experienced. There was a lack of capacity within our regional BBS, Bring Back Staff teams, because they had a lot of people interested. Now, where it worked well was when, and critical care nurse had just left 3 years ago, 2-3 years ago, in their local unit, and they still had a relationship with them, and they rang them up. That's when it worked very well. Interestingly, though, the NMC does hold data on their branch of nursing, whether it's paediatric, mental health, adult, but doesn't hold data on their specialism. So doesn't have a data about, so these amount of anaesthetic nurses, theatre nurses, critical care nurses, A&E nurses. And if we'd had that, I think we would have been able to concentrate on those first.
Yep.
And then maybe we wouldn't have seen the lack of BBS regional capacity like we did. So the bottlenecks, there was pre-employment check bottlenecks, and there was also a difference between what returners by then are wanting to do. When we got to wave 2, of course, though, a lot of these people went into the vaccine programme. And I'm grateful for everybody that came back to help us. And I think what my email does show is there was a lack of data on deployment.
Well, you also make the point there in the Scott makes the point in the bottom bullet point that 15 to 20% of those that opted in to temporary register withdrew from the process prior to deployment. The regions are working through this, but there are a number of reasons. Changes in circumstances, for example, people self-isolating, individuals not wanting to work on the front line, and then there was the pre-employment checks and individuals not returning their contract. A multitude of reasons as to why initial interest did not always translate to nursing in the wards.
Yep.
All right. Can I just ask you this? Is there any merit in always having a temporary register, do you think?
The NMC does not have the legislative ability to set up a temporary register, whereas the GMC do. It is part of the legislative reforms that are being considered. But yes, that is something that they do need the ability to have.
In short, if there needs to be a temporary register for whatever reason, there's got to be legislation passed to deal with the NMC aspect of it, whereas the GMC already have a ready-made legislative power to do it.
Yes.
All right, okay. Can I go back, please, to 421158 and look very briefly, if we may, Dame Ruth, at the two other ways of increasing capacity? We've just got to revert back to a different document, or it's in your tab too, if it helps you. Thank you very much. Second way to increase capacity was encouraging those skilled who are currently on the register but not working in clinical care to come into clinical practice. Who was this aimed at?
It was aimed at the many staff that were in organisations. So there were people in governance teams that are a nurse by background that could support. It was aimed at people in our ALBs, in my own directorate, in Health Education England directorate. It was aimed at those people that were still on the register that could provide support.
Thank you. The third way was changing the nature of the programme from undergraduate nursing and midwifery students of the last 6 months of their programme, so they may be delivered in a clinical placement. I think it's a 3-year degree for nursing,
Yes,
is that
it
right?
is.
And so just help us, what was the plan in relation to the students in the last 6 months of their programme? If it helps you, I'm at about paragraph 116 in your statement, Dame Ruth.
That would be very helpful, thank you. 116.
I think you say there the NMC requires 2,300 hours of academic study
Yes.
and 2,300 hours of supervised practice-based learning for those student nurses, is that right, and midwives?
Yes, so for students, they needed to be supernumerary. They're
What's that?
supervised, they're not in the numbers. They are there to learn. They are learners. Of course, we then needed to change the standards, the educational standards for these learners, for these students, to be able to be working in critical care, therefore without their supernumerary status. But we wanted their work to be able to be counted towards their educational studies. So the NMC needed to do that, and they worked very, very supportive of us, and they needed to do that across the whole of the 4 countries. This wasn't something that we could just be done for England, and that's why working with my team, my CNO colleagues, was so important.
I think you said in your statement that it had been identified that there were 18,700
Yes.
nursing students in their final 6 months, so potentially nearly 19,000 nurses that could start helping out. Is that across England or the UK?
That is across England, but I need to make a correction because that is nursing and midwifery.
Okay, thank you.
So it was 16,547 for nurses and 2,175 for midwives, and together that made 18,700.
Can I ask you this about the student nurses and midwives, though? They're finishing their academic studies, they're doing their practical supervised learning. Did you receive any feedback about how young nurses and midwives coped when they were deployed onto the front line? It just seems, if I may put it like this, a baptism of fire. What did you do, or how did the CNO try and help cater for that specific cohort of nurses and midwives?
So this was, again, one of those tough decisions that, again, I took to my strategic advisory group, this group of very senior, experienced nurses, and none of us wanted to do this. We wanted to continue their education, but we're in such a position that we needed to increase workforce numbers. So we made the decision collectively, we debated it. We wouldn't do first years because they were literally only just out on placement in the January. We wouldn't do third years we'd only do them in the very last cohort. Now, the last part of their training. It was not mandatory to do, though. It was a choice by which people were able to make. And people did make that choice not to go onto the front line, and we respected them to do that. The second years, though, we wanted to continue as much as we could, so they still had one day in their university to keep them linked in. There were risk assessments, but this was not an easy decision. But student nurses were amazing support. And their feedback, and the 7-point plan review fed back, there's lots of surveys that the Health Education England colleagues did at the time, fed back what more support we needed to do. That's one of the things the RCN wanted us to do, which we did do, was to make sure they got sick pay. So it was difficult, but they were amazing.
I'm not going to ask you about the temporary register at point 4. Can I just briefly touch on international recruitment? I think you said in your paragraph 141 that the process of recruiting internationally is not new. It's been a long-established process within the NHS. But in reality, given the lockdowns, was it possible to boost the nursing numbers by international recruitment during the pandemic?
Yes, it was.
How did that happen?
Through a lot of hard work by a lot of directors of nursing and colleagues in the teams. We were recruiting between 5,000 and 6,000 international nurses anyway. And we've welcomed international nurses since the very beginning of the NHS, with the Windrush generation, with Philippine and Indian nurses back in the early 2000s, and then this big recruitment campaign. But of course, restrictions like global travel affected everybody. So there were times, particularly at the beginning, that early summer, when nobody was travelling. So even those people that were due to come weren't able to come, they were delayed. Then, of course, there were the closing of the OSCE centres, which was the clinical training centres.
So that meant that international nurses couldn't go through the requisite training to ensure they had the same standards as applied in the UK, is that right? Or in England?
So in the UK, they could go through the training, but they couldn't go through the assessments. And that was, so in peace times, what happens, and now, an international nurse would come over, they're internationally educated, they're trained in their own country, they then have to go through an OSCE assessment of their clinical skills in order for them to go onto the permanent register. With the OSCE centres closed, and they didn't open until July 2020, we would have to use these international nurses in a different way, and that's why we came up with a temporary register with them as well.
Would a number of the international nurses be from a black and ethnic minority background?
Yes.
Given that we know that they were disproportionately impacted, was there any thought given to whether it was the right thing to do to ask black and minority ethnic nurses to come to the UK and potentially face the consequences of a disproportionate impact on them? Was any thought given to that?
Yes, of course. So in wave 1, they were here. In wave 2, of course, as we were headed towards the winter of 2020, by that stage, all black Asian minority nurses had had a risk assessment, and some had been removed from clinical frontline care. So, yes, of course.
Okay. Can I deal with one other topic, please, perhaps before we take a break, if I may, and it's in relation to redeployment. And can I ask you, please, Dame Ruth, to turn to paragraph 166 in your statement. And in particular, I'd like to examine redeployment to critical care and changes to patient and nurse ratios. And you've already referred to that.
Which paragraph? Sorry.
Probably easier, actually, just to go straight to paragraph 171.
171. Thank you.
And if we could have on screen, please, INQ 421-219 0005 as the page reference. Thank you very much. can you just help us in non-pandemic times, in critical care, what should be the nursing to patient ratio?
Critical care has patients on a ventilator needing high level of intervention and with highly skilled staff. So always, 24 hours a day, there is a trained critical care nurse. And let me just spend half a minute and tell you what that is, because
How is that different from I don't mean an ordinary nurse, but you understand there's a distinction.
So I'm a registered nurse, like many, many thousands of other nurses. I have had experience and a qualification post my registration in theatre nursing, which meant I was a trained theatre nurse. It's the same with critical care. These are registered nurses, all with some experience, and many of them many years' experience, but all trained in additional level of skill and expertise, all with an additional qualification. So these are true experts.
And they tend to the sickest patients, if I can put it like that, in theory, one-to-one in non-pandemic times.
Yes, and obviously with medical colleagues, part of a multi-professional team, with the pharmacist, the physio, and other colleagues.
During the pandemic, however, was there a decision taken to change the patient to nursing ratios?
Yes.
And who made that decision, please?
All 4 countries made that decision, and for us, the decision formally was made by NERB.
By NERB, the National Incident Response Board.
Yes.
Is that right? Were you part of the decision-making process?
I led it.
All right.
So,
Can I ask you then, how is it that you came to take the decision that in some cases we may need to go from 1 critical care nurse to 6 patients?
yes, so Sunday, 22nd of March was a day that I will never forget. Started off at 9 o'clock in the morning when we had our meetings, and I was being told that we've got 4,000 critical care beds in England, but in 16 days' time we're going to need 7,000. But I had a meeting at 1:30 actually on the Sunday with the British Association of Critical Care Nurses, Nikki Credland as chair, excellent critical care nurse leader, and one of my deputy CNOs, and of course with some other critical care nursing experts. And they'd been doing some great work, this work. They'd been talking to colleagues from across the UK and other colleagues within their profession that this could be a proposal to take that forward. A team approach. Not ideal at all. And I know there's been consequences because of it.
Let me pause you there. It's not 1 to 6, maybe slightly misleading, because as you can see there are other staff as well performing roles. You've got staff A, staff B, but they are not those with critical care training skills, are they?
No, staff A are nurses with recent or past critical care experience, and staff B are nurses with no critical care experience, and staff C are with healthcare support workers. So it was much more of a team. So I worked as a staff B, and I was on a 1 to 2 ratio at that time, working in my local hospital. And it didn't feel like a 1 to 2 at all, because when somebody went for a break, it wasn't a quick cup of tea and back. It was taking all the PPE off and back on again. So it was a 45-minute experience. So it actually felt like 1 to 3. And that's why in wave 2 we didn't do this. We did this in...
Before we come to wave 2, what happened then when the one critical care nurse who's looking after 2, 3 or 4 patients needs to take a quick comfort break? Who was there to fill the gap?
There was always a 1 to 4. There was people that would cover for each other. But there were occasions when there were 1 nurse to 6 patients, 1 critical care nurse to 6 patients. There were other professionals. This is a decision that will stay with me forever.
Dame Ruth, do you think that the diluted staff ratios affected the care that those patients received?
Yes.
What about the impact on the critical care nurse themselves? Inevitable impact on them, I assume.
Inevitable. And what we now know with Kevin Fong's work, for example, and that's why we launched the Professional Nurse Advocate Programme for critical care. But yeah, this was not where we wanted to go.
Why did you do it? Why did you make that decision then?
Critical care capacity was doubling, trebling, quadrupling, 10 times the capacity in other places. We were seeing reports in Italy where patients weren't able to get into hospital. Yeah.
You mentioned, and perhaps we'll pause then after that if we may, my lady, you said we didn't do it in wave 2. Why not?
Because 30th of July 2020, Professor Kevin Fong's briefing shared with me the impact that it was mainly having on nurses. So we developed the Professional Nurse Advocate Programme, we developed a whole range of practitioner health, but I made the decision then that we're not doing this again. But it was a critical care shift that I did in January 21, a Sunday morning, and I had my regular meeting with the Secretary of State, Matt Hancock, at the time the next day. And of course, there's the pressure of getting on with the electives again. And he said to me, why can't we do 1 to 3 ratio all the time? And I said, no. I was there yesterday morning and I explained to him what it was like. He backed me and we did maximum of 1 to 2 during the next wave.
All right. My lady, would that be a convenient moment?
Certainly. I hope you're warned that we take regular breaks.
Thank you.
You might welcome one as well. I shall return at 25 past.
Thank you very much.
All rise.
Kerry.
Thank you, my lady. Dame Ruth, can we turn, please, to a different topic, and that of the IPC guidance? And it starts in your statement at paragraph 230 onwards. I think you were the National Director of IPC for NHS England, is that right?
Yes.
And as you told us, you were the co-chair of the Hospital Onset COVID Working Group.
Yes.
And you say in your statement you have national responsibility for NHS England's COVID-19 nosocomial infections programme.
Yes.
Turning to the guidance itself, at paragraph 232, you say that NHS England's role in the guidance was through the membership of the CEL. You brought together the leads and specialists from across the UK. Initially, the CEL provided comments on draft guidance, but from June 2020 onwards, the UK IPC CEL drafted the guidance. Right. And as I think, if I've understood your evidence from this morning correctly, you would then see that guidance and have the opportunity to comment on it, agree, disagree, amend as you saw fit?
Yes, and indeed the draft guidance would go back to each of the countries for their equivalents and their public health and their leaders to consider as well, before it then went to PHE for final approval.
I think you say in your statement that you don't have specific scientific and technical expertise, and you say it's not my role to make decisions on issues such as PPE specification and the use and types of disinfectant to use. I just want to be clear what you mean by that. When you say you didn't make decisions on PPE specification, what did you mean there?
I mean that the scientists provided me and across the UK the advice on the scientific elements of the IPC guidance, of which that was it. For my role was much more about providing executive leadership, supporting the conversation, supporting the coming together of UK-wide discussions as part of UK-wide CNO discussions, supporting, for example, the National Clinical Director, Professor Mark Wilcox, when I was going with him to the senior clinical group, and indeed supporting Dr. Valeri Davies, the microbiologist, the public health doctor in Wales, when she presented the consensus statement in late 2021.
All right, but she in due course, I think, became the chair of the IPC cell after Dr. Ritchie.
Year.
I just want to be clear, was it part of your remit to say, I don't agree that it should only be FRSM, I think it should be FFP3?
My remit was to challenge, to ensure that the scientists have taken the latest evidence. And the scientists were the public health doctors and the UK IPC cell, which had a range of professionals within it from across the UK.
So if you thought that a wrong decision had been made about the level of masks, for example, that should be worn...
I would question it.
Right. And then it would go back to the cell for their view.
And indeed questioned Dr. Susan Hopkins, Professor Susan Hopkins and Jenny. Jenny and I and Susan and I had many a conversation, as did the National Medical Director, Steve Paris, with Susan and Jenny. Chris Whitty.
Sorry, I didn't mean to interrupt you.
Sorry, I apologise.
Were you familiar with the different modes of transmission of this respiratory virus? Contact, airborne, droplet?
Yes.
Are you a scientist by background, familiar with the physics and engineering and droplet sizes?
No, I am absolutely not. I needed to rely on public health specialists and other specialists.
Can you help us, at the beginning of the pandemic, what did you understand to be the mode or modes of transmission of COVID?
I understood it, like the World Health Organization was advising at the time, to be mainly droplet, but of course with aerosol, particularly then, that's why we had the guidance for AGPs, so that we supported, it was making sure that we had guidance for aerosol generating procedures, but at that time all of the guidance, all the advice, scientific advice, was predominantly droplet.
Do you accept that on the back of the scientific advice, consequential decisions are made about what IPC measures should be put in place?
Yes.
All right. And so droplet goes down one or a number of routes for IPC. Aerosol and airborne transmission may require different IPC measures. In general, do you agree with that?
In general, IPC measures are a combination is not just around masks. Masks are very, very, very important, but so is distance in between beds, so is eye contact, eyewear, gowns, gloves, a whole range of measures.
Did you gain an understanding as the pandemic progressed that aerosol transmission played a larger part in the way that the virus spread?
Yes.
Can I ask you, please, about December 2020? We heard from Dr. Ritchie yesterday it's not in your statement, that Public Health England were telling the IPC cell that they thought that their understanding about aerosol transmission had changed and there was a bigger role that aerosol transmission was playing. And Public Health England recommended a move to FFP3 masks on a precautionary basis. Now, that was not the position the IPC cell came to on a consensus basis. But Dr. Ritchie told us that there was a paper produced and that you and the senior leaders saw the paper. So can I ask you about that, please? Do you remember being made aware that Public Health England had come to a changed view about the role that aerosol transmission had played?
I remember that the Public Health England member of the IPC cell had come to a potentially different view. I'm also aware of UK colleagues from public health backgrounds had a different view. There was a consensus. Now, I'm also aware that because of a differing view, I wanted to make sure we belt and braces, and that first statement was agreed by the most senior medical scientific advisor in PHE/UXA.
When you say that first statement, what do you mean there, Dame Ruth?
That statement you're talking about then.
That their understanding had changed?
Yes. The consensus statement end of 2021, I'm sure we'll come on to later. But
So
Could you just complete?
yes, let me deal with it. You became aware then that PHE's understanding had changed. You were aware that the consensus cell had come to a slightly different view. It was raised with you, I think you said you agreed with. Did you agree with the decision of the IPC cell?
I took assurance that there was a debate. I was actually pleased there was a debate. I didn't want groupthink. I wanted to know that people had the confidence to debate the merits of the evidence and the merits of potential action. So in terms of process, for me, that was good. I took assurance that there are other colleagues across the UK from all sorts of professional backgrounds that had a differing view. But I also wanted to make sure that PHE's more senior doctors, I wanted to know their views.
Right.
And we did have their view.
Pause there. The question I asked you is, did you agree with the decision of the UK IPC cell?
Yes.
Even though you said you were concerned about having, sorry to interrupt,
Not at all.
belt and braces.
Yes, because my role has always been to challenge, to ensure that everybody's looking at the evidence that has got the scientific evidence, scientific background.
But surely a belt and braces, or what I think some have been calling the precautionary principle, would involve going down the path recommended by the Public Health England member who said FFP3 masks. Wouldn't that be belt and braces?
I think at that time there was nobody other than, as you said, my lady, saying there was evidence for FFP3s all of the time. What I also know was I wanted to seek PHE's most senior doctor's view of whether the guidance needed to be changed on FFP3. And we did that. And the view was we didn't need to change it.
You say that you rightly wanted to avoid groupthink, and as you may know, it's something I reported on in Module 1. Did you ever consider that there might have been an element of groupthink when it came to the mode of transmission? That the groupthink, including the World Health Organization, was the mode of transmission was droplet?
I don't think we did, because there was the World Health Organization, there was the UK IPC cell, like we know, it's got lots of people involved with very technical and scientific expertise. There was the senior clinical meeting with every UK CMO, CNO, AXA chief exec, the senior medical, plus some of the other deputies in there. There were so many people in so many different groups. There was the hockey working group as well, with another range of people. So there were so many different groups saying that. And even today, as I understand it, World Health Organization hasn't come out and said it's predominantly aerosol.
Melody, may I just finish this topic in this way? When you came to learn that Public Health England had a changed understanding of the route of transmission, did you speak to anyone in Public Health England about that and what underpinned that change in understanding?
Can I just check for clarity? It was that December 20.
Yes, it is. 22nd and 23rd of December 2020.
Yeah. There is email correspondence. I think I recall it was Mark Wilcox talking to Susan, but I also know my National Medical Director spoke to PHE colleagues. I can't recall whether that was Susan or Jenny, so I apologise.
Did you speak to any
I don't think
colleagues?
I don't think I did, but I can't recall.
Right. And what about Sir Chris Whitty? Did you speak to him and say, well, PHE have got a slightly different view here, Sir Chris, let's discuss the merits or otherwise of it?
I think we discussed it at a senior clinical meeting, which Chris was chairing. I'm absolutely sure we did.
Yeah, I know. They haven't said that. They've said it. Thank you. All right. Can we look at some of the specifics in relation to PPE itself? Now, you are not responsible for the supply of PPE. You make that clear in your statement. But I think you say in that statement at paragraph 252, Dame Ruth, that you became aware of supply issues. And can you just help us? How did you become aware of problems with PPE supply?
Oh, numerous ways. From regional chief nurses feeding back, from the UK IPC cell feeding back, and indeed the first time I became aware was the 16th of March when the then head of IPC, Linda Dempster, told me and my deputy CNO that there were PPE supply challenges. From the incident, strategic fusions, when their feedback from the EPR colleagues, from me going to talk to care home colleagues, from me, there were PPE from the RCN, Dame Donna, yeah.
A number of different sources there.
Yeah.
I think you make clear you were not involved in the decision to declassify COVID as a high consequence infectious disease. Obviously, you're aware that it was classified and then declassified. And you were not involved in the decision for IPC guidance to recommend FFP3 masks only in intensive care and or when AGPs are carried out. All right, but you're aware that that's the background and where we end up, essentially, by about the 6th or the 13th of March 2020. Okay.
Yes.
Were you concerned that recommending only FRSM to the vast majority of healthcare workers in the guidance in March 2020 did not sufficiently protect those healthcare workers?
I think I was more concerned at the time about supply, because that's what was being fed back to me all of the time. So if I think back to, I think it was the 3rd of April 2020, when I had a webinar with my National Medical Director, Sir Stephen Paris, with medical directors, chief nurses on the webinar. Susan Hopkins very helpfully came to present the tables guidance. It was all about supply, it wasn't about the guidance. So the main concern that was coming into me was supply.
All right, well, let's look at that supply issue, because I think you say that there were concerns about supply through March and April 2020. There were increasing reports from frontline staff of PPE shortages. Concerns were discussed at the senior clinicians group on the 9th of April. And a pinch point effectively coming here around 12th, 13th of April. So I'd like to focus on that, please, for a moment. Is the position this, that there was a discussion regarding gown use amongst the senior clinicians and indeed a number of the people that you've spoken about? Can we have a look on screen, please, at INQ 477782? And it's behind tab 13, Dame Ruth, but it might just be easier to look here. Here we are, 12th of April, an email to you from Dame Donna Kinnair of the RCN. She's had a discussion with you, wants to confirm my discussion with you that the RCN and you as our CNO would not support sending nurses or healthcare assistants to look after patients without the appropriate PPE equipment as determined by the WHO guidance and the recent guidance that we supported that PHE issued on the 10th of April. Whilst we recognise that PPE gowns are in short supply with the possibility of us running out, our stance would be that sending nurses to look after patients without appropriate protection is a failure of our duty of care to them as individuals and in breach of health and safety legislation. Issue was with gowns, clearly. Do you know why there was an insufficient supply of gowns?
Yes. The pre-pandemic planning stockpiles did not include gowns. And that left us extremely short. It was a very stressful time. It was Easter weekend, and Donna and I spoke more times than I spoke to my family, and she spoke to her family. We were completely aligned that we needed to concentrate on getting more gowns and not moving to aprons, because that wouldn't protect nurses in the way we felt they needed to be protected.
I think the IPC cell in due course, and certainly the guidance, recommended what's called sessional use.
Yes.
And reuse. Can you just help us? What is sessional use, please?
When you use it for a session, so you use it for the time you're in caring for patients. So I, for example, when I used it, and Donna actually, when we did it in Nightingale and indeed in my other ships, you'd go in your head, your mask, your eye contact, wear your gown, your gloves, and your gown would be for the session that you were in there. When you came out...
How long might this session be?
3 or 4 hours. Or, yes.
And...
be different in different
well, let me ask you this
places.
then. In non-pandemic times, in 3 or 4 hours, how often would you expect a nurse to change their gown?
I don't know what a HSID unit would do day in, day out in a normal time. I would have to come back to you on that. But I genuinely believe it would be a single use for a single patient.
Right. So if you've got 6 patients in a bay, you might change your gown 6 times. Or is that... I don't want to be overly simplistic about it, Dame Ruth, but is the bottom line that in non-pandemic times you would have changed your gowns more than you did when
Absolutely.
they were recommending sessional use? All right.
As indeed we would have more staff on a 1-to-1 ratio in a normal time.
Yeah. So here is you and Dame Donna not supporting the proposal for sessional use or reuse.
And I then also talked to my strategic advisory group, my forthright directors of nursing, and they were equally of the same view, as was the UK IPC cell. And my deputy CNO at the time then fed that back. Donna and my main concern was the safety of our staff, and we just felt that this wouldn't be a safe option.
Well, that was the question, was how do the nurses feel about this guidance? Did you get any feedback from the front line about what they thought about sessional use and reuse?
I can't recall about sessional use versus reuse. I can recall how frontline nurses were in fear of not having gowns and going potentially with just aprons, which is why Donna and I were aligned and agreed so much.
By Easter 2020, this is obviously a major issue for you and your other colleagues. When did you first bring it to the attention of Mr. Hancock as Health Secretary?
Of the supply of gowns.
Or the supply problems of
Supply
PPE?
problems. I can't recall an exact date when I...
Roughly?
I'm sure Mr. Hancock was aware at this time that we were struggling with supply. Of course, my colleague Emily, Dr. Emily Lawson, was supporting the DH, and the DH was leading this, and I'm sure they would have been made aware. I also was on the podium at number 10 with Mr. Hancock. I think it was the 3rd of April, and I think it was the 10th of April, something like that. So he knew then, because we were talking about it. In fact, I talked about it in...
My lady, may I interrupt to help to this extent? We're going to hear from Professor Hopkins, and I think it's clear, unless my memory's failing me, that this change to sessional use and reuse was in fact agreed by Mr. Hancock, so he was aware that there was A, the concern, and B, the change in the guidance in this regard. We'll perhaps deal with that on tomorrow.
I'm not sure if you're the right witness to ask this question, so just say if you're not. As a layperson, I've never quite understood the concept of use-by dates for PPE if it's made of cloth. Now, I can see how, if over decades, cloth might weather, but why does PPE have a use-by date?
As I understand it, the Health and Safety Executive have that as a rule for the protection of staff. So I think it may need to be asked of them.
Yeah, sorry,
my lady.
No, not at all. Can I just deal briefly, Dame Ruth, please, with a little later on in the pandemic at paragraph 266, if it helps you. The Alpha variant emerged in the end of 2020. And I think we then had Omicron later in due course, and that did not necessarily result in a change in the IPC guidance. But I think you led you commissioned the IPC cell to review the IPC guidance in November 2021. What led you to asking the IPC cell to review the guidance at that stage?
I remember that it was the UK CNOs were meeting, and actually we discussed it as a group, and Sue Tranker, she was my deputy, but then she was a CNO of Wales, she emailed on behalf of the UK IPC, on behalf of the UK Chief Nursing Officers. But yes, we all agreed as a UK.
And what was it? Just that Omicron had emerged by then, and that's why you asked for the review to be undertaken?
Yes, it was. We knew it was more transmissible. that was coming out. So yes, we wanted to do that.
I think
It was also in June 21, from the 1st of June 21, because following a steer from SAGE, SAGE, the most senior scientific advice, they were saying that within the IPC guidance, staff could wear respiratory protective equipment such as FFP3 masks following a risk assessment process. So that came on the back of the June as well, June 21.
what was the outcome of the November review that you asked the IPC cell to undertake?
The outcome was a consensus statement that was drafted by the UK IPC cell. Dr. Larry Davis was the chair by then from Wales, so it was a truly multi-UK-wide consensus discussion. And then that went to the senior clinical meeting for a discussion.
I think you say in your statement that the consensus that was presented ended up in a document which supported the existing position
It did.
on FFP3 use in the guidance, noting there was provision in the guidance for extended use of RPE following a local risk assessment, but agreed to make this position clearer to staff by stating this at the start of the guidance. So, in short, if a risk assessment suggested that FFP3 should be worn, then that ought to be provided to the staff member. Is
Yes,
that right?
And that was in place from June 21.
Yeah. Now, but why is it?
this-
I'm sorry to interrupt you. Can I just ask you this on that point? Why is it necessary to move the reference to risk assessments, making it clear at the start of the guidance?
Because the feedback was that it wasn't as clear as it needed to be. So the consensus was we needed to make it even clearer to frontline staff that they had the ability to have a risk, where a risk assessment indicated, they should be able to wear an FFP3.
Was there any concern being relayed back to you that the risk assessments, although recommended in June 2021, were not in fact being undertaken?
I recall colleagues being fed back about whether they'd had a risk assessment recently or moved an area, which is why one of the reasons why it was moved up, but also one of the reasons why we did webinars with chief nurses and medical directors to reinforce the messages to them. And I remember doing webinars with chief nurses and medical directors that said, and we are reinforcing the fact that local risk assessments need to be done, and if by then you need a member of staff needed to have FFP3s, they should have them.
I understand that is what should have happened, and if the risk assessment recommended FFP3, it should be provided. What about the staff member or the nurse or midwife who just wants it for their own peace of mind? In those circumstances, would you have expected them to have been provided with an FFP3 mask?
I know that there were units, there were staff that would do that.
So that was an option still, even if the risk assessment and the guidance didn't necessarily drive you to that conclusion.
Absolutely.
May I turn to a different topic, please, Dame Ruth, and some challenges in particular in relation to maternity care. If it helps you, it's at paragraph 310 in your statement. I think you set out in that paragraph 5 challenges. I just want to ask you about 3 of them. There were challenges with staff absence due to illness and self-isolation. There was obviously the concern about the impact of COVID on pregnant women. The implementation of cohorting, what do you mean by that? What was the challenge there?
So I remember very well that there were units, of course we had women that had COVID, women that we weren't sure had COVID, women that we definitely knew hadn't got COVID. So of course, estates had directors of nursing, chief midwives, the labour ward coordinators were having to make sure they provided safe care and separated care for women to protect the women and the staff.
I think you are aware that Amanda Pritchard, the now CEO of NHS England, has said in her statement that nursing and midwifery staff, due to their age profiles, were forecast to be the worst affected group for absences. Is that right? All right. Against that background, can we have a look, please, at a table in your statement at page 69. So it's INQ. Thank you very much. This table, I think, sets out some of the impacts of staffing pressures on maternity care.
Yes.
And if we just look at the top box to start with, due to the current pressures experienced across urgent and emergency care services, LAS, London Ambulance Services, that are no longer in a position to guarantee an ambulance response to women choosing to have a home birth or birth in one of London's 3 standalone birth centres. And the risk is set out there in no uncertain terms. Should there be an obstetric emergency requiring transfer to hospital, there will be no ambulance response to respond. You set out there that midwives are legally obliged to attend a birth, and LAS, London Ambulance, have been asked to discuss this decision with a view to various options. How did it come to pass that if a woman wanted to give birth at home, not go to potentially a ward where she might get infected with COVID and or infect babies and or infect the staff, we ended up in a position where she wasn't allowed to have that choice? Do you know what led to decisions like this?
Yes, I do. So we had over 700 vacancies, 800 vacancies of midwife roles before the pandemic. And you've already heard me say that because of the bursary, we could have had those 700 there. But moving on, that each day, regularly, pre-pandemic and post-pandemic, a midwife in charge of a midwifery service at any of our local hospitals would balance operational pressures with staff absences. But these were of a different scale. Midwifery-led care in a home birth situation is often with 1 and sometimes 2 midwives. So it's particularly resource intensive. Now, whilst women quite rightly wanted to have their birth preference supported, in wave 1 in particular, and I know that my Chief Midwifery Officer, my National Clinical Director for Obstetrics and Gynaecology wrote to me the 23rd of March with this table. At this time, of course, LAS capacity was stretched to the absolute limit because they were transporting patients to hospital with COVID in huge numbers. So it was a difficult situation. And we know that I think it was 57% of birthing units closed during that period. But London closed all of their units.
Well, can we just close that box? I just want to look at one other different type of concern. The third box down, potential withdrawal of epidurals for non-emergency situations are being explored. The choice of epidural for pain relief during labour may not be available, and therefore women's choice of pain relief will be limited. Was there a supply problem with epidural pain relief? The use of epidural for pain relief?
Yes. So anaesthetists were a key member of the team supporting patients that were ventilated on critical care. And I believe you heard last week that we didn't, again with workforce plan, we didn't have enough anaesthetists going into the pandemic. There were women that had their epidural delayed.
Maybe not a question for you, but do you know how that was resolved? Did we manage to get more pain relief, or was there an alternative option offered? Can you help with any way that was they tried to manage that?
So the 9th of April guidance did advise that anaesthetists need to be freed up for labour care. Equally, I know that anaesthetists worked extraordinarily hard to get to provide that care. And there was only a small amount of women that didn't get it. But that, I don't want to trivialise, there was even a small amount of women that didn't get it.
No. All right. One of the other challenges that you are aware of in relation to maternity care was women not accessing maternity care at all. And I think you say in your statement that there was a NHS Open for Business campaign launched, pregnant women being one of the main target audiences. Did you become aware of the reason or reasons why women did not want to access maternity services during the relevant period?
Well, there was the stay-at-home message that was around, but of course some people still needed to access the NHS, and that included women, of course. We know that there was messages to women, and indeed I gave a message at my second number 10 conference on the 10th of April, that please, particularly aimed at pregnant women, if you need to contact your midwife, please do. And it's important they did. And then, of course, this campaign was launched on the 25th of April.
Can you think of any way in which the messaging could be done differently to try and encourage people to access necessary health services in the event of a future pandemic?
Of course, women were pregnant women were put on the vulnerable list that was developed, and that probably caused even more concern for them. There were lots of women, though, that had very, very good care from their midwifery teams and their obstetric teams. I know the Royal College of Obstetric and Gynaecologists and the Royal College of Midwives really supported professional leaders, as well as my own team, in making sure the cascade in the message, which was pregnant women still need to access, because of course it was an area of work that couldn't be stepped down. No. It wasn't like elective care. So this needed to continue.
Do you think the stay-at-home message got the balance wrong?
In hindsight, I wish it was stay at home, but not if you're pregnant or you are. In hindsight, yes.
Yeah, all right. And I think in particular, during wave one, you became aware of evidence that there was a particular reluctance to access maternity services from Black, Asian and minority ethnic communities. I'm at paragraph 339, Dame Ruth. And did that result in, I think, 4 specific actions being taken to try and encourage women from those communities to come forward? Can we look on screen very briefly at 280429, please? _2. can you see, this is taken from, I think, the Maternity Transformation Programme, but can you see in the middle there, the England's most senior midwife has recommended the following common sense steps, increasing support of at-risk pregnant women, e.g. making sure clinicians have a lower threshold to review, admit and consider multidisciplinary escalation in women from a BAME background, reaching out and reassuring those women with tailored communications. There's a recommendation about vitamin D, and ensuring that all providers record on maternity information systems the ethnicity of every woman, as well as risk factors such as living in a deprived area, comorbidities, BMI, whether they're age 35 or over, to help identify those most at risk of poor outcomes. So that was the recommendations. But do you know whether there was any positive uptake as a result of those recommendations, or whether any review was done to see how efficacious or otherwise they were?
So the Chief Midwifery Officer, the then Chief Midwifery Officer, wrote those 4 areas out. It was about reinforcing the message. So, for example, vitamin D, a supplement, has been there as an advice for a long time, way before the pandemic. I know that there was a CQC survey done that was done, asked the questions in 2020 and published in 21, that actually showed that white women felt that they had enough information about their pregnancy, 74% of white women, and 81% of women from a Black Asian minority background felt that they had enough information. So clearly some of that messaging did get across. And of course, local organisations, local trusts, local midwifery teams would be able to tailor some of their communications to their populations. And that was really important. It's the tailored communications that was important too.
Can I ask you about visiting restrictions in the context of maternity care? I think, is this the position, and correct me if I'm wrong, was the guidance that partners should be allowed to accompany a woman in labour?
Yes.
Is that correct?
Yes, it was. So the 16th of March guidance said visitors should be limited to one per patient or less, unless it's a partner in a birthing situation. And the same with the 25th of March. And that was just after lockdown, the first national lockdown, which is visitors suspended except for birthing.
Yeah, so generally speaking, no one allowed into the hospital unless one of the exceptions applied. And one of those exceptions was that if you were in labour, you should have your partner with you, or a partner with you. All right. Now, did you draw, or are you aware whether there was drawn any distinction about active or non-active labour?
Yes.
What was the guidance meant to be? Was it meant to draw a distinction, or was that something that was created by those who were in charge of trying to manage visitors?
It was the latter. You know, this must have been really difficult for chief midwives and labour ward coordinators and the like, because they were trying to balance their staff safety and the women and baby safety. So whilst 97% of women had their partners in labour, half of them only, or half of them, had it during active labour. Now, there is a definition for active labour, but in practical terms, it's when a woman goes from antenatal ward into the labour suite. So that would have been tough for some of those partners not being, and for the women not being there in the antenatal, as well as then in the labour.
So although the guidance didn't make reference to whether a woman was in active or non-active labour, it was interpreted by those on the ground, as it were, to be a potential dividing line as to when partners were or weren't allowed.
I think, yes, I think it's one of those learning points for me for a future pandemic about being more specific earlier.
Do you think partners should have been allowed in for the entirety of labour?
Yes, I do.
Were you aware of reports that some women felt obliged to undergo a vaginal examination to prove they were in active labour and therefore get their partner in with them? Did you hear reports of that?
I heard reports of that, and when I talked to Jill Walton, the Chief Executive of the Royal College of Midwives, some of that could have been true. I find it hard to believe that a midwife would do that. So it could be in translation, I don't know, but in practical terms, it's when a woman moves to labour ward.
Can I just ask you this? When you became aware that there was this distinction being drawn between active and non-active labour, did you or the Chief Midwifery Officer put out any communication to say that's a distinction that shouldn't be being made?
So what I am aware of is that there was some work done by the Royal College of Midwives and the Royal College of Obstetricians over the summer of 2020, which led to the 8th of September guidance, which was much more specific. And a regret I have is that wasn't that specific detail in the 8th of September guidance wasn't in the original guidance.
I think in your statement you say that by the first week of April 2020 you'd had reports coming to you and indeed to the Chief Midwifery Officer of not only partners not being able to attend the full range of appointments, scans, partners not being able to stay with their mother and the baby immediately after birth. So a range of difficulties in relation to people accompanying pregnant women. I think you say in your statement that decisions about which scans were able to be attended with, how long the partner could stay after the birth, were decisions for trust to make. Is that right?
Yes.
Do you think that led potentially to an inconsistency of approach, with Trust A doing one thing and allowing a partner in, and Trust B doing something different and not?
Well, of course, their estate is different in different organisations. So what may be safe for staff and for women in one unit may not be the same in others. And some of our estate in maternity units is extraordinary and has great facilities that will allow for this much easier. Some of our NHS estate in maternity services, for example, in sonographers for ultrasound rooms, is very tight, very small. And that created a difficulty in practical terms for those leaders and staff.
If there had been more PPE available early on in the pandemic, which the visitor, the birthing partner, could have worn, do you think that might have affected the stance taken on visiting restrictions?
I don't know. I wasn't involved in the visiting restrictions consideration. That was the clinical cell reporting into the EPRR structure. So I can't tell you whether PPE supply was part of the decision making. I can tell you, though, that midwives were nervous, as were nurses were nervous, and Royal College of Nursing and Royal College of Midwives, quite rightly, were equally advocating for the support of their staff to be considered.
If there had been more testing available earlier to show that the partner was COVID negative, do you think that might have affected the way the visiting guidance was drafted and published?
Oh, without doubt. Without doubt. So it wasn't until the 14th of December guidance that, you know, one of those key actions was around, we had LFD, we had the lateral flow tests. We if we'd had lateral flow tests at the beginning, with us being able to say whether a partner was positive or not, gosh, that would have relieved a lot of anxiety and tension between staff and women and families, and provided better outcomes or experience.
Can I ask you briefly about postnatal support? Do you consider that to be an essential part of maternity care that should be prioritised in the event of a pandemic?
Absolutely. Antenatal care with the scans, postnatal care, I agree completely.
Did you become aware that health visitors were being redeployed and so were not able to visit new parents?
I was made aware of that, and Alison Morton from the IHV very helpfully made me aware, as well as, of course, the Chief Nurse for Public Health, that I didn't have responsibility for health visitors and school nurses until November 2023. But yes.
The IHV is the Institute of Health Visiting,
Yes,
is that
it
right?
is.
Can I ask you about face-to-face support for new parents? Clearly some meetings had to be done virtually, but do you think that there should be more prioritisation of face-to-face support for those new mums and dads?
I think it was the IHV very helpfully set out concerns about how we should not redeploy health visitors away from their core duties. Future pandemic health visitors should stay being health visitors. They should not be redeployed. And then they would have more ability to do the face-to-face contact.
Can I widen the topic of visiting to more general restrictions on visitors? Clearly you were working on the front line at times. What was the impact on patients and indeed staff of not having a visitor when you broke an arm, had an appendix out, whatever the position may be? What was it like for them?
Awful. It was particularly with end-of-life care. And whilst the visiting restrictions were done to reduce the footfall, to reduce transmission and to support the balancing of staff safety, I can understand if I had a loved one in hospital at that time, like I did actually.
Different topic, please.
Just before you move on,
sorry.
And what about those who needed extra support? So, for example, I think we heard about people who are disabled, or I think we heard from a gentleman whose daughter was Down syndrome. And what about people who needed the extra support? Must have been dreadful for them. Even worse.
Yes, although I do believe the guidance was there that people with a learning disability, to have somebody to support them, would have been there. And in practical terms, the vast majority of times that would have happened. But these were scary times for staff and for patients and for carers. If we'd had testing at the time, we could have tested more easily and allowed more people in. Difficult decisions, my lady.
Another difficult area, if I may, and DNACPRs, do not attempt cardiopulmonary resuscitation. Did you become aware of any instances of the inappropriate use of DNACPRs?
Could you direct me to my...
Yes, I think you did with it at
I've got it.
paragraph 364,
I've
Dame
got it.
Ruth.
Sorry, I apologise. Yes, I did become aware early in 2020. it was raised with me directly, actually, at number 10. I think it was my first number 10 experience on the 3rd of April. And DNACPR is a very sensitive area, very important area, an area that is part of end of life care planning. It should be done sensitively, it should be done with the patient and with family if possible. I've been part as a nurse in the past, being part of those conversations. But to blanket DNACPRs was wrong.
Yeah. You, I think, in your statement say that in April 2020, you co-signed a letter along with NHS England's National Medical Director to reiterate that blanket DNACPRs should not be used. And I think you said that the issue was raised again with you by the Queen's Nursing Institute in September 2020. And I suppose really the question is if you told everyone in April 2020 to not do it, can you help as to why in September 2020 you're still hearing reports of blanket or inappropriate use of DNACPRs?
So I'm really grateful the Q&I raised this directly with me. As I understand it, the survey was done in May and June 2020, so still after the guidance, the letter had been written. It was raised, I think she said, Crystal was the 16 out of the 163, so it's still there. When I went back to the Q&I, because of the way the survey was done, I wasn't able to find out which of the care homes it was there. But there was a difficulty still in getting the information out.
So, putting the location, I should say, to one side, there still seems to be an issue, notwithstanding the efforts you made in the April 2020 letter. And in March 2021, is this right? You were among senior clinicians who signed another letter reiterating the NHS England position that it was unacceptable for people to have a DNACPR on their record just because they had a learning disability, autism, or both. What prompted that letter in March 2021?
Because there were still further reports coming through. But between all of these, the National Clinical Director for end-of-life care, working in the medical division, was working and taking all of this into the work on advanced care planning. This is something that should not happen.
Also, I've heard on my travels, it wasn't just that there are a number of aspects to their use. The blanket use you talked about with people with a disability without consultation of the patient or their family, but also it wasn't just used as I've been told. I've yet to hear much evidence on it. It wasn't just used for do not resuscitate. It was used for do not treat. That's totally wrong, isn't it?
It is completely wrong. It's a fundamental principle of the NHS, and one that I hold dear as a nurse, or a former nurse now, to care for and treat people on an equal basis. So I fundamentally disagree with blanket DNAR and the same with treatment, my lady.
Can you help as to why you think people merged a DNACPR notice, which is very specific, with escalation of care and end-of-life care decisions? Do you know why they got the two confused or elided them?
Good or best practice, excellence in advanced care planning for end-of-life does include a conversation about DNACPR. If I was in a situation that I was facing a terminal illness, I'd want to have the conversation, and I'd expect people to have the conversation with me. But I wouldn't want it as a blanket decision.
Different topic, if I may, and I have to just deal with a number of discrete issues now, so forgive me if I'm jumping around. Earlier this morning, you made reference to risk assessments for Black and Asian and minority ethnic workers, and it's at paragraph 192 in your statement. And I think you mentioned that you were responsible for increasing the pace of implementation. I just want to go over that so we're clear that what the problem was and what you did to try and solve it. Just help us, please. I think you were aware of the disproportionate impact of COVID on Black, Asian and minority ethnic staff. And I think there was concerns, there was work being done, I should say, around risk assessments for that particular group of people. What work was being done, firstly? Was it just risk assessments?
So this was a piece of work led by the Chief People Officer team. But as, of course, a professional and fellow executive, I inputted into it and I had an opinion. Because, of course, the BME Strategic Advisory Group had raised it with me and I was in regular contact with them. The risk assessment was key. The risk assessment is a conversation about a person's risk to working in a frontline COVID environment. And without the risk assessment, action couldn't get taken, which is why I was very keen, probably forthright, in wanting it to be brought forward so it was achieved sooner, because without the assessment, the action would be delayed.
So was it in short that the plan for implementing the risk assessment was going to be within 4 weeks, and as a result of your efforts, that came down to 2 weeks to roll this out? Is that where we get to?
Yes, I proposed that it would be 2 weeks. I cannot recall whether the 2 weeks was achieved or not.
Right.
I'm sorry.
Do you know why it was that a 4-week period had originally been suggested?
Because it's a huge task. And I'm not criticising my colleagues at all, because it's a huge task. It's one that we would be requiring a lot of energy and effort of trust leaders.
Do I take it, though, that you felt that the 4-week period was too long?
Yeah, I wanted it sooner because without the assessment, the action couldn't take.
Do you know whether the effects of those risk assessments were monitored and reviewed to make sure that it was happening and it was helping BAME nurses and midwives?
This wasn't just for nurses and midwives, of course. Yes, the CPO team would have been monitoring this, the implementation and the impact. I also know from my own feedback, though, that people were being assessed.
Different topic. It's my fault. I touched on the issue of long COVID earlier this morning, but I didn't, in fact, ask you when it was you as CNO became aware of the effect of long COVID on healthcare workers. Now, I don't mean a precise date, but can you pick a point in the pandemic where it came to your attention?
I'd have to go back to my notes to give you a more accurate picture, but I'm very grateful to Dr. Elaine Maxwell, who brought forward the concerns around long COVID. I'm so sorry, I can't recall when that was. I don't want to give you a false date.
Just before we conclude, please, Dame Ruth, can I ask you some questions really about the health and well-being of the nurses and midwives that you led? And can I ask you please to turn to paragraph 182 in your witness statement? I think you speak there in particular of surveys conducted on critical care staff, and that work was being led by Professor Kevin Fong, and the output of those surveys was shared with you. And could we show on screen, please, 421181. It's behind your tab 10 if you want to look at it, but it might just be easier to use the screen. And was this the note that he provided to you?
Yes, it was. It's a note that was dated the 10th, as I recall, but I received it on the 30th of July, 2020.
Right. And we can see there just the summary for these purposes. It notes, assesses the impact of wellbeing and psychological health on the frontline ICU and anaesthetic workforce. There was a pilot survey across 5 hospitals, more than 700 respondents. And there is evidence of significant psychological harm to frontline NHS staff following the first COVID surge, with high rates of post-traumatic stress amongst frontline professionals. When you received Professor Fong's summary here, what steps, if any, did you take to try and establish, A, whether it was right, and B, try and ameliorate the harm that was caused?
So I was raising back in May 2020, before I received Kevin's report, the need for something of a wellbeing service specific for nurses. Obviously, the wellbeing work was very good and developed very quickly and was accessed widely, but I was wanting something more for nurses. So I started asking my head of nursing to develop the professional nurse advocate programme. But when I had Kevin's briefing, I met with Kevin virtually, but I met with Kevin several times. As more data came out, I met with Kevin. I believed his data, I took his data, and I wanted to make sure that we did everything possible.
Pause there, because I'm going to ask you about the programme in a moment. But is this the position that at the end of July 2020, I think you attended a psychological harm roundtable and reported to people at that roundtable that 4 staff nurses had died by suicide, with 1 further nurse in ICU and a member of staff who'd made an attempt to take their life?
Yes.
Now, against Professor Fong's work, the reports you made at that roundtable, tell us please about the professional nurse advocate programme. What was it meant to do? What did it actually achieve?
So the professional nurse advocate programme was a programme of restorative clinical supervision. It came about by my experience, what I was hearing, and my head of mental health nursing, mental health nurse by background, saying, oh, we're going to need to provide some more support for particularly critical care nurses. So we developed a programme, and it was a programme that supported nurses in their workplace.
Give us an example. What did it actually do?
Have a conversation, check in with people, make sure they're okay, debrief. It was there as a support. It was very successful. The feedback from it was very successful. And of course, then we needed to roll it out. And I think that's what my comments were on that round table. It wasn't just for critical care nurses we need to do this. It was for those that needed to go into critical care. And of course, what we realised was there were lots of nurses elsewhere that wanted this. And so it's been more rolled out. I put in more money into it from my budget. And we developed this, Kevin was involved with the development of this and saw it in reality. But it wasn't the only thing we did, of course. We ended up having practitioner health as well opened up for nurses, which was really important.
Can I ask about you, please? Is it right that as part of your role as Chief Nursing Officer, you were the victim of abuse meted out to you online?
Yes.
Can you just give us a couple of examples of the kind of things that were said to you? Or summarise it in whatever way you can, Dame Ruth.
Yes. The one thing I have learned throughout the whole of this is the importance of acting with integrity. And sometimes that comes at a cost. And sometimes you have to make decisions or be involved in decisions that mean that, in social media in particular, you are vilified. Or by some other senior people, you're vilified. I wasn't the only one. But it was pretty horrible.
The future, if I may. If you were to try and summarise what worked well for the nursing and midwifery profession, what would you say?
The workforce expansion worked well. The students that came, all 23,000 of them in wave one, to support us. The international educated nurses that throughout the pandemic, joining the temporary register, joining the substantive register, worked well. Delivering the 50,000 extra nurses early and overachieving worked well. Very well.
What did not go well from the nursing and midwife perspective?
A number of areas. So we went into the pandemic with vacancies, nearly 40,000 vacancies. We could have had 5,000 less.
Yeah.
The maternity visiting guidance, I genuinely believe could have been more specific earlier. And that would have been better for women, better for their partners, and better for the staff. And if we'd only had testing in the early days. If I think about the nosocomial transmissions, if only we had testing, because we didn't have testing even for day 3 testing until 20th November. So it wasn't just we didn't have testing to begin with, we didn't have testing for a main part, a big part of the early pandemic.
If you could make a recommendation or two to her ladyship to consider, what would be your top picks, if I may put it colloquially?
Ensure we have the workforce supply and everything we can do to either bring back the full educational package or write off of debt. But the domestic supply of future nurses and midwives in this country is key to a future pandemic. And second, my lady, it would be that we're able to have testing. Because not only would visitors have been back earlier, staff would have been safer, but patients would have been safer too.
My lady, they're all my questions. There may be a number that you wish to
There was just one other one I wanted to ask. You mentioned just then about things that didn't go well, and you talked about visiting guidance with maternity care. Presumably, you would add to that visiting guidance when it came to people who required carers. You remember I asked you about people who had difficulties and relied on a family member for support. If that guidance that you say should have been followed wasn't being followed, presumably you'd say that too is something that ought to be.
Yes. I said the maternity because that was extremely difficult for lots of women, but it included people with a disability of whatever disability too. I agree with you.
Thank you very much indeed, Dame Ruth. I can't believe that people could be so stupid and wicked as to subject you to the kind of personal abuse that they did. Just ignore them. I'm afraid it looks like it's a fact of life, and it is a dreadful fact of life. So I'm sure we're all genuinely sorry that that happened to you. I know it can't have been easy giving evidence today, reliving not only your own experience, but the experience of your colleagues. So thank you very much indeed for your help.
Thank you.
Right, I'm asked to break now for lunch and come back at 20 to 2.
Thank you, my lady.
All rise.